Hi, my name is Atif Darish, professor and consultant of obstetrics and gynecology. This lecture is targeted to gynecologists who are practicing hysteroscopic surgery, as well as anesthesiologists confronted with cases of hysteroscopy, particularly advanced hysteroscopic surgery like hysteroscopic myomectomy or adhesolysis. We have to know that the uterus is completely different from the bladder. And if you are doing hysteroscopy, you should not use any term or any rule related to the bladder in the hysteroscopic surgery, simply because the bladder is different from the uterus, as it is thin-walled, distensible, and capacious. It can tolerate up to 500 cc's or more of urine in females, and it is actually a real space hollow organ and can be inflated even with gravity without any pumping system. On the other hand, the uterus is a potential space. Normally, the uterus has a very small cavity as the walls are directly opposing each other, and it is thick-walled and requires high pressure to inflate it. It is tight organ, not capacious, and pressure is needed to inflate the uterus or to distend it. So distension of the uterus is more risky than the bladder, and I don't recommend that doctors of hysteroscopic surgery use the term of TUR, prostate, which is not suitable for the uterus because we have to use a term of operative hysteroscopy, intravascular absorption, OHIA syndrome, which is actually different from the TUR, as organ is different, the patient is different, and the fluid also is different. We know that hysteroscopic complications are too many, including some technical problems, some anesthesia problems, and one of the complications of hysteroscopy actually is distension media complications, particularly fluid overload and its sequelae. If we discuss the fluid used for distension of the uterus during hysteroscopic surgery, we have to put in mind three criteria of this fluid. Number one, is this fluid viscous or not? If the fluid of high viscosity, like honey, this means high viscosity fluid. If it is of low viscosity, like water, this is a low viscosity solution. This is number one of the questions you have to ask yourself when you are confronted with a hysteroscopic surgery. Number two, regarding this solution, is it isotonic, hypotonic, or hypertonic? Which means that the solute outside and inside the cell, when are using this solution, is equal, or the solute outside is higher, or the solute inside is lower, which means hypertonic or hypotonic solution respectively. So the third point of the solution, does it contain electrolytes or not? So if the nurse brings to you solution for hysteroscopic surgery, these three criteria should be fulfilled in your mind: electrolyte content, tonicity, and viscosity. We have some examples. We have saline, which is of low viscosity, isotonic, and electrolyte rich. So it can be used for energy of bipolar diathermy, cannot be used for monopolar because of its electrolyte content, and also can be used for mechanical instrumentation like using scissors or grasping forceps. While some other solutions are electrolyte-free, like glycine and sorbitol, they are of low viscosity, hypotonic, and electrolyte-free. Mannitol also, but isotonic, and dextran, which is high viscosity, hypertonic, and electrolyte-free. The high viscosity solution is the best regarding viscosity because it does not mix with blood, immiscible with blood. So good visualization, no excessive fluid to wash blood clots from the endometrial cavity. And this is the best solution. And actually, it is the only solution used for hysteroscopy of high viscosity, and others are of low viscosity. But later on, just few minutes, you will see that it is not a good solution, is not an ideal solution, despite excellent visibility. So we have viscosity, and we have tonicity and electrolyte content. The important question, you ask the team in the OR that I need an ideal distension media for hysteroscopy. They ask you what are the criteria of this ideal solution. It should be non-conductive to be used with monopolar diathermy, so it should be electrolyte free. Number two, it affords clarity and does not mix with blood. And this can be achieved when you are using high viscosity solution. And importantly, this solution should have low incidence of side effects. So it should be electrolyte free, high viscosity, and isotonic, of course. If we apply this rule on the available solutions used for hysteroscopy, as mentioned in many textbooks, you will find none of the following fluids fulfill the criteria of ideal distension media. As the saline is electrolyte rich of low viscosity, glycine, sorbitol, mannitol, low viscosity also. The only one of high viscosity is dextran. The only one with electrolyte rich is saline, others are electrolyte free. The isotonic solutions are saline and mannitol. The glycine and sorbitol hypotonic, and dextran is hypertonic solution. So these are the different available solutions used for hysteroscopy in a common way. None of these solutions is ideal. So in conclusion, you will work with one of the solutions, but you should know that these solutions have some side effects because they are not ideal for hysteroscopic surgery. We can discuss saline, as I told you, but the serious effect or the side effect of using saline as a distension media can occur if you infuse a lot of fluid input inside the body, a lot of saline, and this can lead to volume overload, heart failure, pulmonary edema, and death. But it cannot cause hyponatremia or hypoosmolarity because it is isotonic. On the other hand, glycine and sorbitol can cause hypotonia, hyponatremia, and hypoosmolarity, and their sequelae simply because they are hypotonic solutions associated with dilutional hyponatremia. The mannitol is less causing hyponatremia, hypoosmolarity, but can cause fluid overload, and also these side effects can occur, but to a less extent because it is isotonic. And lastly, dextran is high viscosity, good for visualization, hypertonic, electrolyte-free, but it is associated with serious side effects like allergic reactions, anaphylaxis, fluid overload, even with minimal amount DIC, and destruction of instruments as it is sticky to the telescope and instruments at the same time. Now we are doing hysteroscopy, how the fluid goes into the body of this patient. This can be achieved by disruption of the endometrial and the myometrial venous sinuses, and during resection or cutting of this part of the uterus, you will open sinuses and vessels, and this leads to systemic absorption of the fluid media into the systemic circulation. So the higher the procedure technique and duration, like myomectomy, metroplasty, endometrial resection, the higher risk of fluid overload. Putting in mind deep myometrial penetration of the lesion like myoma type 2, increased intrauterine pressure, large-sized uterus, or the prolonged procedure, all these are contributing factors for absorption of excessive amount of fluid. And you have to know that the pressure of the fluid pushed inside the uterus should be kept at the mean blood pressure, which is 100 millimeter mercury or less. If it is more than 100 millimeter mercury, the fluid will go to the maternal circulation. But if it is less than 50 millimeter mercury, you cannot see because of excessive bleeding. So the optimal pressure is 60 to 80, not exceeding 100 millimeter mercury. Importantly to know that the patients subjected to hysteroscopic surgery, if she is young with estrogen in her system, this estrogen has suppressive effect on its pump, which regulates flow of electrolytes through the blood-brain barrier. So being young age or premenopausal is another contributing risk factor for increased fluid overload due to the affection of the centers regulating the flow of electrolytes through the brain barrier. We should know that what's called fluid deficit is the difference between the input of fluids and output of fluids. Fluid overload occurs when there is excessive intravenous fluids, intrauterine fluids, and retrograde transtubal leakage of fluids. If this outweigh the output, which is suction unit, urine output, and perineal bag. The recommendation of many societies regarding fluid deficit, which is the difference between the input and output, in cases of hypotonic solution, they recommend not to exceed 1 liter for the healthy patients, which means that the difference between the input and output should not be more than 1 liter if the patient is healthy, not more than 750 milliliter for the patients with comorbidities or elderly. And at that point, the surgeon should stop the procedure even if the procedure is not complete. And this needs collaboration and cooperation between the anesthesiologist and the surgeon to stop the procedure when the maximal fluid deficit level has been reached. But if you are using normal saline, which is isotonic solution, the maximal allowed fluid deficit is higher than hypotonic solution. It can be up to 2.5 liters for healthy people and up to 1.5 liters for patients with cardiovascular disease or comorbidities. Again, you have to stop the procedure when you reach this fluid deficit level. We used 1.5% glycine for a long time because of the advantage of electrolyte-free availability, cheap price. And so this fluid is going back nowadays, and we don't use it too frequent in our daily practice due to the following problems of glycine. In this slide, I tried to summarize to you the serious effects of the glycine when used for distension of the uterine cavity. Firstly, you have to know that glycine is exposed to oxidative deamination process and with the subsequent release of ammonia, and excessive ammonia in the blood can lead to hyperammonemia and hyperammonemic encephalopathy with nausea, vomiting, disturbed mental level, muscle pain, and decreased visual acuity. So this is the first serious effect of glycine on the brain, can lead to encephalopathy. Also, the overload with glycine leads to dilutional hyponatremia, and hyponatremia can lead to hypoosmolarity because sodium and its anions contribute to the majority of plasma osmolarity. And this hyponatremia can lead to cerebral edema, seizures, coma, brain herniation, and death. Also, the premenopausal status with the effect of estrogen on the regulatory centers of the electrolytes in brain is should be put in mind if you are working in the premenopausal patients or young patients. Putting in mind the metabolic acidosis is another sequelae of the intravascular hypervolemia with pulmonary edema and brain swelling, and also hyponatremic encephalopathy. These are serious effects of glycine, and we have to add to these effects of this serious hypotonic solution the stress of the patient, which will lead to decreased antidiuretic hormone with decreased diuresis and retention of fluid in the circulation of this patient. So this distension media actually is serious and should be used with caution. That's why the recommendations to the fluid deficit in this solution not to exceed 1.5 milliliter as in healthy individual and not more than 750 cc in patients with comorbidities. And of course, hyponatremia, if the normal serum sodium decreases less than 135 to 145. Less than this level can be mild, moderate, and severe, and actually is treated by hypertonic solution like 3% saline, and actually, in addition to diuretics, and actually it needs a multidisciplinary team. We have to remember the anion gap, which is difference between positive and negative. Positive is mainly sodium and potassium. Negative is bicarbonate and chloride. And this is acid-base balance. And normal pH is between 7.35 to 7.45. And acidosis is considered when the pH is less than 7.35. And anion gap should be more than 12 if we take the difference between sodium and potassium at one side and the bicarbonate and chloride at the other side. Because this drug is serious and this solution may cause some serious effects, we try to minimize the risks of glycine during hysteroscopic surgery. And since a long time, we use a dual infusion set, which has two arms of tubing. One is connected with saline and the other is connected with glycine. And we use saline whenever no firing of the electrodes. And this means that you use saline for washing the endometrial cavity, for removal of tissues from the endometrial cavity, and so. But once you are starting to fire the electrode, you have to use glycine because it is non-conductive of electricity. And by this way, we achieved minimal fluid of hypotonic fluid infusion into the endometrial cavity and the abdomen and the systemic circulation. And we found after this randomized controlled trial recently published that this technique of dual irrigation is associated with decreased glycine dose and decreased side effects. And previously, we compared glycine versus saline, hypotonic solution versus isotonic solution in a randomized controlled trial. And we found that the use of bipolar resectoscope with saline is much more superior to glycine with monopolar diathermy regarding hyponatremia and hypoosmolarity. And this table shows at 30-minute and 45-minute of the operation, the level of glycine, the level of sodium decreases in the glycine group significantly, and also hypoosmolarity decreased after the operation. And this study is very important to highlight the value of introduction of saline and bipolar resectoscopy in the hysteroscopic surgery. And actually, it has been cited several times, and it has been recently cited in one of the review articles on complications associated with the distension media. and saline is important to be introduced because, as I told you, of isotonic property, less liable to hyponatremia, less liable to hypoosmolarity, and no ammonia toxicity. But it is electrolyte rich, should be used with bipolar or mechanical hysteroscopic surgery, and of low viscosity, which means it mixes with blood, or so the fluid should be excessive to wash this blood to have proper visualization, and this is a disadvantage of saline. What are the complications of saline? They are, as I mentioned, mixing with blood, fluid overload, and this can lead to heart failure, pulmonary edema, and death of the patient. The treatment of fluid overload with saline is much more easier than the fluid overload with hypotonic solutions because it does not cause hyponatremia or hypoosmolarity. So the treatment is a cardiovascular support by CVP line, oxygen to the patient, and cardiac stimulants, fluid restriction, diuretics, of course. Some studies put a sphygmomanometer cuffs on the different limbs of the patient to minimize fluid overload to the heart. And we have to consider intraoperative echocardiography and chest X-ray to exclude pulmonary edema or cardiac changes. We have to put in mind what's called retrograde transtubal leakage, which means is that the fluid goes from the endometrial cavity to the peritoneal cavity via the patent fallopian tubes. And this occurs if the intrauterine pressure exceeds 80 millimeter mercury. And some studies addressed this important source of leakage of fluid into the peritoneal cavity by performing laparoscopy concomitantly with hysteroscopic surgery, and they found that transtubal passage was not correlated with the intrauterine pressure. And the same group published more or less similar study with more or less similar results. So when to suspect retrograde transtubal leakage, you can suspect them if your patient has decreased oxygen saturation by pulse oximetry lower than 90%, which is unsatisfied oxygenation, no evidence of fluid overload, normal urgent echo and X-ray chest, ultrasound shows some free fluid in the abdomen, and blood gases do not show any change except partial pressure of oxygen decline. Other factors of the blood gases or other items are normal, like pH, like potassium, sodium, bicarbonate, and base excess. So you have to suspect that the fluid goes to the peritoneal cavity, in this case with decreased oxygen saturation via the patent fallopian tubes. So we from this part of the lecture, we knew that the distension media are not ideal. Every type has its unique disadvantages. So we have to prevent fluid overload to prevent complications of these distension media. And this can be achieved by preoperative and intraoperative steps. Before the operation, you have to check that the patient has comorbidities or not, because the fluid deficit is related to the comorbidities. For hypotonic solution, 1 liter healthy, 750 milliliter for the patient with comorbidity. For the isotonic, 2.5 liters and 1 liter for the isotonics patients with comorbidities. Also, you have to define the expected procedure time and the lesion extent, and your timing of the operation should be post-menstrual with preoperative hormonal preparation, sometimes like progesterone, COCs, or GnRH agonists. And we performed a study on the myomata and found that GnRH agonist decreases the size of the myoma and also decreases intraoperative bleeding and decreases fluid overload when the patient has been prepared for 3 months by GnRH agonists. And you have to include fluid overload and retrograde tubal leakage in the preoperative consent for the patient, and the patient should know that this can occur as a complication of the hysteroscopic surgery, and she has to consent for performing any procedure like laparoscopic aspiration of excessive intraperitoneal fluid or other procedure to save her circulation. Intraoperatively, you have to be very quick. You have to check the infusion and suction units. You have to coordinate with anesthesia, and you can inject some diluted vasopressin to minimize bleeding and close the make vasoconstriction of the blood vessels. And the intracranial pressure should be kept less than or lower than the mean arterial blood pressure. It's better to use electronic hysteromat. The flow rate should never exceed 100 milliliter per minute, which means in 5 minutes, you should not exceed half liter of the solution, and in 10 minutes, 1 liter of the solution. And the ideal is to infuse 40 to 50 milliliter per minute. And this can be achieved when you are using automated infusion pump, but manual pump cannot judge the flow rate of the fluid infused to the uterus. And this is a disadvantage of using primitive or manual pumps. You have to insert Foley's caster from the beginning of the procedure to monitor urine output. As I told you, the pump infusion safety system is much more superior because it shows the infusion rate or drip rate per minute and also the pressure, while manual approaches are or primitive pumps are not used. It, by the way, is not recommended at all, and it is prohibited to use any pump designed for laparoscopy in hysteroscopic surgery because of the high flow rate and high pressure that may lead to sudden death of the patient. And fluid deficit, which is difference between input and output, can be calculated every 10 to 15 minutes by subtracting the fluid in the perineal bag and in suction canister and the urine output. Subtract this collected fluid from the infused fluid intravenously and intrauterine. And we can suspect perforation if there is rapid increase in fluid deficit and, of course, poor visualization due to bleeding and collapse of the endometrial cavity. You have to consider retrograde transtubal leakage by abdominal examination and intraoperative ultrasound, as I already mentioned. Some studies used ecopolics to minimize fluid overload. Others deny the role of these ecopolics, and we used ergometrium before in a previous study on large submucous fibroids and achieved better results, particularly in type 2 submucous myomata. Now, the role of anesthesia is very important in hysteroscopic surgery. Not all anesthesiologists are suitable for anesthetizing hysteroscopy unless they have good knowledge of the hysteroscopic surgery, because hysteroscopic surgery patient is different from other patients. You are dealing with the patient like any patient, but you are dealing with a distension media. You should know the nature of this fluid. Is it isotonic or hypotonic, hypertonic solution? And what about the fluid deficit? And what about the risks of the procedure and how much expected fluid deficit? And you should know the recommended deficit for healthy and patients with comorbidity cases, and also the energy modality used. Is it monopolar, bipolar, or mechanical energy? So orientation of the anesthesia by hysteroscopic surgery is completely recommended to have proper anesthesia. Generally speaking, recommendation of many societies is to go to regional anesthesia rather than general anesthesia to minimize the risk of brain losing control, because if you give regional anesthesia, the patient is conscious and her reaction to you is very important to guide you against any serious side effects of the distension media. So regional anesthesia should be put in mind for the hysteroscopic surgery. And you can use TIVA for short procedures like diagnostic hysteroscopy or fine adhesolysis and so. And if the surgeon uses paracervical block, don't give opiates, but you have to give non-steroidal anti-inflammatory treatment to minimize pain or uneasiness. And opiates are not recommended because we need the brain of the patient. Also, you have to restrict intravenous fluids. Always we mention to the anesthesia, just keep the intravenous line patent and give drugs through it. And don't infuse fluid for the patient because the fluid will come from the uterus to the circulation. Don't worry and don't give excessive fluid, as excessive fluid intake during surgery can cause fluid overload in the body. And avoid hypothermia. Hypothermia is very serious of the patient, of the fluids and distension media, because it may lead to myocardial ischemia, ventricular arrhythmia, increased risk of bleeding, delay in wake up of the patient, and post-operative shivering. And every liter goes to the circulation of the patient is associated with decreased temperature by 0.25 degrees Celsius. So you have to minimize the hypothermia, and this is very important. And also you have to check the fluid deficit every 10 minutes in collaboration with the nurses and surgeons. And don't forget 3 versa, 3 transuterine, transtubal, and transvenous infusion of fluids versus suction canisters, Foley's catheter, and perineal peg. You can do or order for blood gases in cases of hypotonic solutions, particularly pH, sodium, and potassium. So in conclusion, after this talk, we have to know that hysteroscopic surgery requires synchronization between the hysteroscopist and anesthesiologist. The ideal distension medium is not yet known. Each media has its some disadvantages we have to know and we have to put in mind when you are using this medium. And the distension media orientation of all OR members is mandatory. Calculation of fluid deficit is the key of successful hysteroscopic surgery, and we have to consider retrograde transtubal leakage as a contributing factor for fluid deficit. Thank you very much.